on the hotel. Okay, give me just 1 second to see if this can be fixed or is a dead end. I'm at a conference and on a guest Wi-Fi network in a hotel. And okay, so this one. Okay, that worked. And there's no way to pre-test it either. So I have to be on this Zoom in order to test. So, all right, there we go, done. And now let's try again. Oh, not working. Stop share. I'm going to try one more time. Otherwise, you will need to use a pen and paper instead of what I'm trying to do.
No worries, that's fine. That's yeah.
All right, that so works. This is my sharing is not going to work on a hotel Wi-Fi. So let's do it in the most interactive way possible. So what I want you all to do is to get a writing device of your choice. Paper and pencil would be the most basic, but advanced forms are acceptable too. You can use a an Apple Pencil on an iPad or what have you. I think that's like $500 to do the same thing that a paper and pencil can do. But yeah, it's all good.
As a paper and pencil, so yep.
Okay. And if you have a paper, hold it in, put it in landscape mode.
Okay.
Sort of smiling. He knows where I'm going with this. But this is just the first 5 minutes. I have 4 things that we're gonna cover today. And now on that paper, I want you to draw an arrow going from left to right at the top.
Mm-hmm.
And then on that, so that's a patient timeline, let's say 10 years. And then make a mark on that timeline, a circle or a box or something, when a medical event of consequence could have happened. And you can imagine whatever patient journey that you can relate with, a relative or yourself who's undergone some, you might have something simple like an annual checkup. Someone could have gotten COVID. You could have people getting routines, colonoscopies, surgeries, knee replacements. My dad had his hip replaced. Just lay out those events. Okay, so we have about 51 attendees and 15 panelists. So we're making 66 pictures right now. Well, 60 because I'm not drawing. And then underneath that timeline, starting on the leftmost side, under every event that you put down on the timeline, enumerate the list of types of data that would have been collected. There could be vitals when the individual visits a healthcare system. There could be my health messages. There could be the forms you fill out about other comorbidities and things you have every time you visit a physician's office. There might be preoperative checkups. There might be video visits. Of course, the ICD codes, CPT codes, prescriptions, laboratory test results, X-rays, CT scans, ultrasounds. If someone's unfortunate enough to end up in the ICU, there'll be some variables attached to them. Well, they're not called variables inside the hospital. They're just called monitoring. But then you get heart rate and pulse oxygenation and blood pressure. You can have the same thing, a little bit unreliable and cheap on the outside. Then it's called a variable. There might be data streams from remote patient monitoring. There might be other sources, such as what they purchase, their social determinants of health. audio recordings and video recordings from Zoom and whatnot. If you put your mind to it, you could probably enumerate, 50, 60 modalities. At some point, some molecular measurements will be done, exome sequencing, genome sequencing, proteomics measurements. You might end up with other kinds of measurements, such as, sleep studies, psychiatric evaluations, and whatnot. Now think about, so now you'd have an arrow going left to right, and then you have this list of items that could potentially be measured or were measured in the use case you have in mind. Now ask yourself, as you go left to right, at every time point, how many of these will be measured? We're not going to be doing ankle brachial index at every visit. We're not going to be doing an X-ray at every visit. We're not going to be doing MRIs at every visit. We don't even do a CBC at every visit. Other than temperature and blood pressure and height and weight, there's very few things we do at every visit. Oh, and those ridiculous forms that you have to fill out. I hate those forms. So imagine this construct, this thing that you have in front of you, that is your mental model of a patient timeline object. STARR, our data repository, has 2 million or 3 million such patient timelines. The data lake has most of the data that I mentioned. Not all of it. I mean, they don't have the Zoom recordings, obviously. But the My Health messages, the imaging, the patient reported outcomes, the pain surveys, not everything is in STARR OMAP, but it is in the STARR data lake. So keep that piece of paper. I have electronic versions of it as a slide, which we're happy to send out. But if you draw it yourself, you'll remember this. I want you to be always thinking of data in the form of this patient timeline. And ask yourself, for the thing you are interested in, which modalities of information matter? And how comprehensively are they measured over time? In most situations, point measurements and one-offs, I mean, they're useful for diagnosis, but not for long-term monitoring. All right, so now I'm bleeding into the second point where I wanted to discuss. So we have this patient timeline object. Let's say we have 2 million of them. You can imagine doing multiple kinds of studies using this patient timeline object. They typically fall into, when you mention the word AI or machine learning, they typically fall into, I'm going to automate something that is tedious and boring. 80–90% of efforts tend to be in that bucket. And then the other parts would be, let me look at everything about a human being or everything about a lot of other human beings and suggest something that the physician could not have done herself or himself. For those things which are about automating something tedious, it's easier to imagine the workflow and how it fits in. So automated transcription, reading radiology studies automatically, pathology studies, monitoring for sepsis, lots of things that are being built and sold that aim to automate something that should have been done, is hard to do, or there's not enough labor or what have you. And the minority of things focusing on, let's look at multiple data points or data on multiple people to do something a physician could not have done individually. So from this sort of top level bifurcation, if you are doing studies that are trying to automate something tedious, I urge you to look up this notion of the Turing trap and to avoid it. So Turing test, most of you I would imagine have heard of. You can't, have been using a computer and not have heard of the Turing test, which basically posits that, you evaluate a computer program by its ability to emulate another human being, and another sentient human can't tell them apart. So the Turing trap is something that one of our faculty members, Erik Brynjolfsson, who works at the High Institute, came up with. And the idea being that we fall into this trap of making a computer do things that the human can already do, as in automate something tedious. And we fail to pay attention to have the computer do something that the human cannot do, but it will be immensely valuable. So one of those examples, Saurabh Gombar is going to talk to you about today. I don't know of any physician that can go through 120 million patients worth of data and figure out what happened to similar patients. That is something a single human cannot do. So avoiding the Turing trap. Okay, so that was sort of point number 2. Then no matter what you do, automate something tedious, do something that a human cannot do, ultimately, you're going to be using data, the kinds of things you get in STARR Data Lake, and your algorithmic expertise or data science expertise to do efforts that advance the scientific understanding of medicine, the clinical practice of medicine, or the delivery of healthcare, or the business of medicine. And you got to be upfront and brutally honest about what your end goal is. If you're trying to advance the science of medicine, a good way to tell is you will aspire to publish in Nature Science Cell. If your goal is advancing the practice, you will aspire to publish in JAMA, Lancet, and NEJM. And if your goal is to advance the business, you may publish in Health Affairs or not publish at all and just build products. Now, the reason this matters is that data in the STARR Data Lake can be used to do all 3 kinds of projects. But if your goal is to advance healthcare and you end up doing a project that advances the science of medicine, you will end up waiting a decade or longer to have real patient impact. Nothing wrong with that. You just need to know up front. That's all I'm saying. Because a lot of times the assumption is that I will find a new subtype of disease and a biomarker for it, and the next day patient care will improve. Nothing could be farther from the truth. When the Human Genome Project was done in the year 2000, the headlines of a lot of newspapers said cancer was going to be cured by 2010, 12 years ago. So just don't fall for that. But if you're truly interested in advancing the science, the STARR Data Lake is an amazing resource. And today, hopefully, we'll hear from a few individuals who've used that to identify disease subtypes or reposition therapies or something of that nature. Coming to the practice, we basically want to learn from the data whether what we're doing is improving patient care or not. And one of the projects I'm really excited about that you'll hear today is about using real-time location tracking to give us a readout on does inpatient telemedicine work. And I don't remember offhand if there's a project that will tell us how to advance the business of care delivery today. but watch for it as you go through the day's presentations. All right, so that's the other big vector of thought, science, practice, business. And then when you build a model to understand or advance either science, practice, or business, what happens as a result of the model's output is an interplay of two other things. And there's the model and its output, but then there's the policy that says, given a certain model output, thou shalt do whatever. And then the capacity to do that whatever. And the third leg of this is the net harms and benefits of that action. So in a very simple example, you might have 10 to 14 variables going into the pooled cohort equation that gives you a 10-year estimated risk of a heart attack. There's a policy that says if that heart attack risk is above 7.5, thou shalt prescribe 40 milligrams of atorvastatin. And for all practical purposes, we can assume that statins are in unlimited supply. And then there's net harms and benefits. I mean, there are side effects of statins, severe myalgias and abdominal upset and so on, and questions around whether it induces diabetes and so on, and then a ton of benefits, well documented. Now, very rarely is life so good. I mean, if you happen to be a cardiologist, you have it made. Most of the times, you get one out of these three. You get the model and the policy is up in the air, or you have the policy, but the model is up in the air, and the interventions, harms, benefits are not understood. So no matter what project you do using data and algorithms, worry about these three things. Don't get overly attached to just the model and its output. That is what tends to happen. We report its performance in 50,000 different ways. We worry about its fairness, generalizability, and this and that. But the majority of the downstream impact is determined by the policy, capacity, and the net benefit and harm of the action. And we have to factor that in, as in think beyond the model, to use a marketing phrase from Taco Bell. All right, so that's the third thing I wanted to talk with you all about. And the fourth one is sort of related to the Turing trap that we already mentioned. There's so many other fundamental advances that are happening in computer science. The one I like to often mention is this notion of a foundation model, where you can combine multiple modalities of information into a representation scheme that helps you do a bunch of other tasks. And Percy Liang, a faculty member in computer science, is sort of doing a lot of research on this. There's a Center for Foundational Models Research on our campus. So ask yourself, given everything in the STAR data lake, what are the foundation models that we could learn? So that every time we want to build a classifier for sepsis or peripheral artery disease or FH, or for chronic pain or opioid addiction or what have you, we're not redoing the feature space. We have a learned shared representation, ideally shared between the research.edu universe and the operations.org universe, so that translation of models into practice is a lot faster. So think about all of these things as you go through today. Remember that patient timeline object and the three other things that we talked about: the science, practice, business, the interplay of the model, the policy, and the net benefit of the intervention, and how are we going to leverage the foundational advances in a manner that we avoid the Turing trap. That's basically the gist of my thoughts to share with you today.
Thank you so much, Nigam. I see Todd is here now. So Todd, I'll please say a few words.
Apologies for the scheduling snafu. I had this blocked at a different time, so I had something else right at that moment. So apologies, and thank you guys for jumping in. And I was just here to just say welcome to everybody, which I'm sure you've already done. And thank you for taking your time out to join us for the second annual STARR Summit. And Nigam, I'm sure already introduced himself, and everyone sort of got to meet him. So thank you, and I hope everyone enjoys the day.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.